Mr. Tropic will smile. Respected Medical Director Sir, Dr. Gazi Hasan, Chief Finance Officer, Mohd, Chief Nursing Officer, Madam Mujib, respected consultants, medical officers, principal nursing colleagues, high officials of basic pharmacy class, and other members of KPJ family. A very good morning to you all. Salamat pagi, Shubho Shakal. I am Dr. Isat-E-Rabban, consultant, dental oral and maxillofacial surgeon. Learned audience, you all know we gather here to attend a regular CME program. Our today's CME topic is Geriatric Proximal Femur fracture. Management of femur fracture is a big challenge, especially in elderly patients, due to less flexibility and less osteogenic potential. It has the highest mortality rate among all the long bone fracture. Our today's keynote speaker is Dr. Mahbubul Alam, consultant, orthopedic and trauma surgery. He is a very academic and idealistic consultant in KPJ. You know, we have a panel of experts. Dr. Gazi Firoz Hasan sir, consultant, orthopedic and trauma surgery. Now we will go through the significant achievement of Dr. Mahbubul Alam's life in nursery. Dr. Mahbubul Alam, he has passed MBBS from Sheikh Medical College, Bogra in 2001. He completed the prestigious fellowship from Bangladesh College of Physicians and Surgeons in Orthopeadic Surgery in 2012. He has obtained the certificate training on knee arthroscopy in Konkuk University, Korea and Seoul University. He is the second fellow in orthopedic surgery from BCPS in Bangladesh. Then he started his career as a registrar at Khaja University Medical College at 2008. He also worked as a registrar at International Medical College in 2010. Then he joined as a registrar in a knee center at Apollo Hospital in 2012. From 2016 to 2018, he worked as an assistant professor at Enam Medical College at Orthopeadics and Trauma Surgery Department. He is the proud member of Bangladesh College of Physicians and Surgeons (BCPS), Bangladesh Orthopedic Society. Learned audience, please put your hands together for Dr. Mahbubul Alam. Now, I would like to invite Dr. Mahbubul Alam, please come up on the dais and deliver your presentation. Thank you.
Assalamu alaikum. Honorable CEO sir, respected CFO, CME Madam, my dear doctors and nurses colleague, head of services, and knowledge categories from the Maxillofacial pharmaceuticals. Welcome to my presentation. Yes, my topic is you already know, Geriatric Proximal Femur fracture. And Dr. Mahbubul Alam working here as consultant orthopedics and traumatology. Regarding femur, this is our thigh bone. Proximal femur means proximal 7.5 centimeter from head to proximal part of the thigh bone. Regarding the risk factor of proximal femur fracture, it is a fracture of advances, that is geriatric age, and after 5th decade, that is after 50 years, the chance of fracture is more, and the chance is more in female, that is 2.5 into 1, the double chance of fracture in female age group. And the factor regarding the fracture of this bone is the osteoporosis, and the osteoporosis is more prominent in sedentary lifestyle, that is urban dwelling citizen having coffee, less physical activity, psychotropic drug, and senile dementia that invite osteoporosis. Women have a chance of proximal femur fracture equal to the disease of breast cancer, uterine cancer, or ovarian cancer. 15 to 20% need long-term care facilities after this type of fracture. There is 20% increased rate of death during the first year of following hip fracture. That is, after fracture of proximal femur, chance of mortality is more. There is a graphical presentation of osteoporosis in male and female. The upper one is in male figure and lower one is female figure. The sense of bone sensitivity after menopause is more in female, as a result of decreased estrogen level. Usually the fracture occurs from simple fall, medial injury, 90% cases, and 10% is from other cause. There is a picture to explain the type of fracture in medial injury. Painful fall from a room, where there is less light, and there is an obstacle in the carpeting, or the water in the floor, or electronic device, loose wire cables, or senior citizen talking while in phone, decayed animal surrounding here, if there is obstacle, simple fall, but even in the bathroom, simple fall, because proximal femur fracture. 1 year mortality, that is after fracture, 12 to 36%. High mortality within 4 to 6 months after fracture. High mortality, advanced age, ischemic disease, and mortality is also in male than female. Delayed surgery, in that case, we always suggest for early surgery, that is within 48 to 72 hours. If you delay the surgery, the mortality rate is very high. The treatment principle of this type of fracture: early mobilization, prevent ubiquitous ulcer, atelectasis, that is lung complication, urinary tract infection, thrombophlebitis. Surgery within 24 hours after this type of incidents, and to work within 2 weeks after surgery. Our motto: to make the patient mobile within 2 weeks. Fracture at advanced age. Some question is there, having too many comorbidity. These are the common incidents of diabetes mellitus, hypertension, ischemic heart disease, serious multiple surgery. So when this type of fracture, we are in confusion what to do this type of patient. The question is arise, what to do with this type of fracture? Is surgery is beneficial for the patient, or it will be risky for the patient? The patient party is too much worried. Yes, it is a fracture of old age, but it is a fracture of necessity. The fracture of necessity means there is no chance of conservative management. This type of fracture, operative management is a good option. Early surgery, secured, stable fixation and early mobilization is the motto to prevent complication of this type of fracture. Here are some classification of proximal femur fracture. It may be in the neck region, it may be in the intertrochanteric region, or it may be in the subtrochanteric region. And here is some picture. The first one is the head portion, second one is the neck portion, and third and fourth one is in the trochanteric and subtrochanteric region. And regarding the anatomy of proximal femur, the blood supply of the proximal part of the femur is different from the other part of the bone. Blood supply from the head region, that is from ligamental, is only 22% of the surface area, and the maximum part of the femoral head is covered by the ascending femoral branch, that is anterior and posterior circumflex femoral artery, and some capsular artery also. That is the picture from the head region, that is the fovea cavities, only 22% to 27% some mentioned. And the main supply is from the ascending circumflex femoral branches. There is another picture from the posterior part to show the vascularity of the femoral head. There is another picture. This picture describes the vulnerability of vascular supply of femoral head from the anterior portion, also in the posterior portion. The main blood supply, 80 to 75%, come from the posterior surface. That is why after fracture of neck of femur, it is a common incident. There will be the avascular or necrosis if we delay to do the surgery, and the head portion will be non-viable. There is another picture, architectural arrangement of the femoral head. That is the clavicular pattern that maintains the stability of the femoral head. This is considered during fixation and to see the adequacy of fixation during surgery. Femoral neck fracture, there is a X-ray. It seems to be low, normal, but if we compare with the healthy one on the opposite side, the thing will be clear. Next one. The consideration regarding fracture neck of femur, it is in the capsular area. That is, it is covered by the synovial fluid, not directly covered by the periosteum, only by the endosteum. So healing in this area is come from the endosteal supply. If we fail to maintain the endosteal continuity properly, then the healing will be hampered, or some case it is not possible to get it by measuring. And there is a classification. This is for our portion. We usually classify the non-displaced fracture and displaced fracture. Non-displaced fracture, after fracture, displacement is minimum, or it may be impacted in osteoporosis cases. And displaced fracture, there is a rotation and vascular continuity is totally disrupted. There is some X-ray presentation of this type fracture, minimally displaced to displaced fracture. Diagnosis. In case of non-displaced fracture, it is very difficult to find this type of fracture in normal radiology. There is a confusion whether there is fracture or not. Only in the trochanteric area of pain, X-ray is negative sometimes. In that time, tomograph or bone scan may help to diagnose the non-displaced type of fracture. And the displaced fracture, it is very easy to find out by X-ray and also clinical finding. The patient is unable to put his or her weight on that affected limb. There is shortening of the limb. There is rotational deformity. And X-ray, next triangle is changed. There is a infected non-displaced fracture X-ray looks to be normal, but if you do CT scan and bone scan, it will be evident. There is also a non-displaced fracture. If we compare with right side, there is normal femoral neck. On the left side, there is a fracture neck. And next angle is changed, there is a fracture line. There is also a fracture neck on the right side. There is also a displaced fracture on left side femoral neck. Treatment plan. In case of a non-displaced fracture femoral neck, it is a paste fracture. The good option to put nose pin or cannulated screw, and we keep the patient non-weight bearing for 3 months. There is a picture, CR picture. In case of neck femur fracture undisplaced, we put cannulated heat screw to fix the fracture and to invite good healing. There is a X-ray picture, putting cannulated heat screw, minimally displaced femoral neck fracture to make the head viable and also make the patient mobile. And in case of displaced fracture, what we do? There is several age group. Under 60, we do nose pin or cannulated heat screw. 60 to 80, usually do hemiarthroplasty or bipolar prosthesis. In case of 80, hemiarthroplasty, posterior mood prosthesis. Here is the X-ray picture, prosthetic replacement of the hip. Here is a photograph of total hip arthroplasty. These are the assembling part of the prosthesis, that is head portion, top portion, and the stem portion. Complication of neck femur fracture, non-linear and avascular necrosis is very common. There is another type of proximal femur fracture, that is trochanteric or intertrochanteric fracture. That is the fracture beyond neck, where the femoral shape and neck produce an angular region. Why there is more fracture in the trochanteric region? There are some logical facts here. Sudden change of neck straight angle, that is change of weight bearing area, axis. And it is a prominent bony part, easy fall on the floor, directly hit the trochanteric area and the fracture easily occur. General consideration regarding trochanteric fracture, it is a vascular area, that is highly vascular area. Neck is a less vascular area, directly covered by the periosteum and by the endosteum. So non-linear is less here, but there is some deformity. We classify it stable fracture and unstable fracture regarding the fracture configuration. There is the radiographic illustration of this fracture, type 1 to type 4. Then come another description of this type of fracture, trochanteric area, 2 fragments to multiple fragments. The question regarding the stability of the fracture. If the fracture is 2% relatively stable and more than 2 or 3 fragments or more distal to the neck, the fracture is unstable. There is the X-ray illustration, trochanteric fracture. There is also a trochanteric fracture. And there is a trochanteric fracture with subtrochanteric extension as well as combination. Treatment plan. In trochanteric fracture, we do dynamic hip screw or small gamma needle. There is a fracture fixation with dynamic hip screw. Fracture fixation with dynamic hip screw. There is also a fracture fixation with dynamic screw. These are the example few cases what we done here in our department. In this type of fracture, as there is too many comorbidity and special fracture, in case of fixation of this type, proximal portion is always in soft tissue cover. We do here close reduction and internal fixation. In maximum bone fixation, we do open reduction and internal fixation. As it is a deep area, highly vascular area, and it is junction of limb and trunk. That's why we do close reduction. And CR is mandatory to see the accuracy and during manipulation of operative procedure, as well as putting the screw in the head region. We always need extra support and fracture caving. This type of operation is not possible to do in anywhere. It is surgery usually do in the tertiary level hospital. There is another example with gamma nailing or proximal femur fracture. And there is another picture illustration of this type of fracture by the DCS, that is dynamic condylar screw also. Another example of fracture that we done here in our hospital, there is a proprietary fracture on the right side. We fix it in our hospital with the dynamic screw. Another example, with subproprietary fracture, we also did have surgery here with long dynamic screw. There is another fracture neck of femur. It's a very delayed case. That is after 72 hours. The neck portion is nearly died. And we do prosthetic replacement of right hip joint of this patient in our hospital. There is another fracture on the right side. And prosthetic replacement also done for this patient. And there is another example, avascular necrosis of femoral head. And the patient underwent for total hip replacement on our left side. Regarding this type of fracture, non-union and avascular necrosis is very common. And this is the finishing of my presentation. Thank you, the IT person, who provided your support in this topic. Thank you.
Thank you, Dr. Mahbubul Alam, sir, for your nice, informative and academic presentation. Learned audience, I think we have enjoyed a lot. Now this time for question and answer session. We have an panel of experts, Dr. Gazi, Hasan, Firoz, sir, and our keynote speaker, Dr. Mahbubul Alam, sir. Please come up on the stage and take your seat. Learned audience, feel free and make the relevant questions regarding our today's CME topic. They are ready to give your answer.
Assalamualaikum. Thank you very much for your wonderful presentation. I am Dr. Moderator, Principal, and today is the second day of my journey here. And I have a question that, as we know, these females are more prone to this fracture. So, is there any preventive measure for just to prevent from this problem? Thank you.
Yes, thank you, madam. Welcome to this institute. Regarding question of prevention, okay, as ladies are more vulnerable, in elderly, after 45 there is a huge hormonal change. We call it postmenopausal osteoporosis. one. They have frequent falls because of low vision, either cataract or diabetic retinopathy. They have motion problems like vertigo, uncontrolled blood pressure, or weak muscle balance. All these make her vulnerable to fall. And from the inner aspect, she is weak because of osteoporosis. Then what is osteoporosis? You know, for every square centimeter, if in a healthy people has 1 gram of calcium, she has got 500 milligrams, almost 50%, and it is accelerating with the age. So regarding prevention, we can give her a good environment of living with a walking age, good support, early control of the comorbidities like diabetes, blood pressure, with adequate family support, and prevention of the osteoporosis like physical activity, hormonal replacement, calcium supplementation, like this. These will prevent her and keep her safe, inshallah.
Thank you, sir.
Let me add something. Another important test is available here, that is bone densitometry. It is good to observe the bone distance by doing bone densitometry. This that is DEXA scan is also we do here. If it is in critical level, then to increase the bone densitometry, there are so many pharmacological products that medication use. To improve the bone quality, we need more physical activity, sunlight exposure, the food that containing calcium to maintain that, also improve the bone quality. And another important thing that is in the home environment of the patient. The floor area should be clean, and the bathroom design during the sitting or upright from the common position, if there is a good support, and if there is any visual disturbance, to improve the quality of vision by improving the refraction of the eye, that will increase decrease the chance of this type of fall, and also prevent this type of bad incidents. Thank you.
Assalamu alaikum. Sir, thank you, Dr. Mohd sir, for his brief and excellent presentation. I have to admit the presentation was very well constructed. Thank you, sir. As the presentation was going on, I was watching very carefully, and I felt a very uneasy sensation in my own femurs. It gave me a chill. I don't know why. I think we should be all more careful about our femurs. Sir, I have two questions. One, sir, the timing of surgery. How you advise the timing of the surgery? This is the number one question. And another question, I've seen the more the age, the more is the reason for orthopedic implants. Why is that? Why it seems not suitable for the elderly? Thank you.
Thank you, sir, for a nice question. Regarding the tissue viability, there is a tissue viability without oxygen supply. In case of soft tissue, in case of nervous tissue, in case of heart tissue, there is a different type of its tolerability. Bone may survive maximum 72 hours. Maximum 72 hours. The pupillary blood supply of the neck region, if it is in a displaced position with a fracture hematoma, and that is disturbed by the synovial fluid, and after 2 or 3 days, the head portion is non-viable. We lost the chance to survive the head. Early the surgery can reverse its all condition. In case of non-displaced fracture and the head portion is viable, in that case we put the pin. After removal, we remove the pin. The nephron part survives, which is good for the patient. And if the surgery is delayed, the head portion is destroyed. And putting pin is not helpful for the patient. And that's why we have to go for the hemiarthroplasty or total hip arthroplasty. In case of trochanteric fracture, there is the neck shape angle that is not good supported by the pin, and that is, the device is dynamically screwed or dynamic condylar screw or the gamma nail. And fracture in the proprietary of subproprietary vascularity is high. There is non-union is uncommon. But in case of head, non-union is very common. And sometimes in some centers they directly do total head to improve the quality of the life. Thank you, sir.
Add something. The question was regarding age. Why elderly people need more, less implants or more implants? Okay. This is the strategy regarding the surgery. Why the age group is 65 or 60 is the landmark, cut-off point. Why? Why we go for the arthroplasty of up to 65 and below 65 we want to preserve the head. Why? Question is there. Number one, after 65 he or she has got so many comorbidities. Number one. Number two, she is already or he is already atherosclerotic, already change is there. That second time of survival of the head is very low, and we cannot go for second surgery usually. Usually after 65, redo surgery is difficult. But there is a saying in the orthopedics: life is movement, movement is life. So regarding mobility, we want to give her or him weight bearing from the day 0 or day 1, immediately after surgery. So we prefer arthroplasty. We know that head will not be viable. We know that he or she has got many comorbidities, and our motto is to mobilize the patient. So we do not go for survival of the head. We just exercise the head and replace it with artificial implant. So elderly people need more implant. But regarding 25, 30, he has a hope. We can go for the survival of the head. He can tolerate more surgeries. Even it is non-immunal, he can tolerate more surgeries. So elderly people need more hardware and younger people need less hardware. Okay, sir?
Thank you, sir. That's a very good topic, and thank you, both of you, the expert panels and the keynote speaker, for bringing up this. I mean, I should say this is a very common geriatric issue. I want to comment on the prevention part. I think all of us has a role in our surrounding to make our moms and grandmoms to aware of this. The first thing is, first we have to make them aware, to let them know it can happen. If it happens, they are going to suffer, and not only suffer, the lifespan will be less. There is a mortality relation with the fracture of the neck also, because of mobility and so all those things. So first things first, we go home today, not only the doctors, everyone in this room, and please let your mom and grandmoms, whoever possible, surrounding your family, to let them know and to educate them that this can happen, which is very, very bad for you. And then the other part is a periodical checkup of this group of patients. Sometimes we don't come to the doctor, we don't come to the screening until we get problem. We should do it before this is a problem. Otherwise, you are going to get your mom as a bionic person with all these prostheses and all these things. There is no alternative of the natural things that we have got from our Almighty. Everything has a problem. Prosthesis has its own problem. So to be aware, of course, if there is a problem, we need to get the solution. But prevention is better than any sort of cure. So whoever here, especially the nurses and everyone, the head of services who didn't know these terms, is go and screen your family members and ask your friends and whoever is beside you to do it for the family members. I mean, whoever is vulnerable, our mother, our grandmother, mostly. And don't ignore your father also. So well, one thing is, sir, both of the sir has emphasized how we can prevent. That I'm not going to that. Other thing is, our doctors also, both of the experts has say that 45 and above, there is a bone density, less bone density, osteoporosis, and all sort of things. I do believe every one of us know that. But still, we are not getting many BMDs. Meaning the screening from the doctor's side is also not enough. It's only 4 or 6 in a month. So are we screening our patients? I don't think that less than 45 patients is less in our hospital. But I don't see it much from our doctors either. So we are not reducing the cost of the patient by not doing a PMD, but to put our patient in a vulnerable situation whether they don't know about their risk factors, and we are not preparing our own patients for preventing these things. So the doctors have their roles also, especially from the gynecologists also. You can send this patient to our orthopedic colleague to assess the risk and this one. Because, well, once it happens, okay, it's never going to be a happy phase for the orthopedician. They are struggling with this sort of thing. And even with the prosthesis, the rehab part and other things is not going to be easy for the patient. So please come up, tune your patient that you need to do it. Giving a calcium is not a solution. We have got a lot of patients coming with calcium from the pharmacies and also. So patients got an idea that calcium can prevent pain, calcium can prevent all this sort of thing. This is a very wrong idea. We have to tune our people, our patients and everyone. Nurses have their role also. That please be tuned that this is not the solution. Calcium cannot prevent all the osteoporosis. It's a life cycle. Other thing is, only calcium is not the treatment. There are so many spectrum of the osteoporotic treatment. So please do refer to right person. The orthopedicians are there, our endocrinologist is there. Just don't give a calcium and console your patient that okay, you are doing well. It's not like that. Calcium has its own problems also. We find a lot of patients with ulcers and constipation and all those things. So first thing first is the prevention. We have a role, not when the patient is only in my chamber, but when I am in my house. And another thing is when I get a patient at the geriatric age, don't ignore the screening part. Whoever the patient is up to, it may be internal medicine, it may be me, it may be gynae, anyone. Even the ophthalmologist, when you find a cataract, don't forget about these things. Please send to your colleagues or do counsel the patient to go for a health screening for the geriatric patients. We have all these things. So that's a little comment from me. So no question. Thank you very much for bringing up this.
Thank you, sir, for your nice comment. I think it is an important issue to improve the quality of our senior citizens. We have a good government program that is EPI. They do some activity to improve the health of the side-based group. But in case of our senior citizens, now time has to come to find out this type of problem. Mask program to screen this type of problem, to especially improve the osteoporotic fracture. That is a disaster. Fracture in old age group, having too many comorbidity that compromise the patient life, also increase the burden, economical burden, and doing surgery is not so easy. So it is easy to screen before the fracture. And simple measure to increase the bone density midweek. There are so many pharmacological products, so many measures, and very helpful. Thank you, sir.
Sir, Assalamu alaikum. Thank you for your elaborate presentation. I am Dr. Shajat Hussain. Sir, I have a question beside this topic. Sometimes we have to face many female patients with both hip replacement or bilateral hip replacement or unilateral hip replacement. They want to conceive or want to bear a child. After the hip replacement, can they bear child, or if a female want to bear a child, can we replace the hip?
Thank you. Then this is the after part of the surgery. Okay, lifestyle should be some restriction is there, but you have to know why replacement was done. Why replacement was done? If it is for a malignancy and she or he is undergoing chemotherapy or radiotherapy, then it needed expert opinion for conceivement. Okay, and usually this goes straight forward. She can conceive otherwise. But regarding normal vaginal delivery, if where the needs wide abduction, there may be some restriction, maybe some restriction, but regarding the implants, where the posterior dislocation is common after hip replacement, modern implants are there which prevents posterior displacement. So I think she can go forward.
Actually, after hip replacement, pregnancy and delivery is a very valuable pregnancy that is not contraindicated. If it is from replacement, as for example, early hip replacement, what is required? Some diseases that cause avascular necrosis, and the disease species is there, and modern treatment facilities is enough to survive the baby and have a safe baby with a surgical procedure. That's not a contraindication.
I want to comment on this one regarding the pregnancy. This is an amazing thing. The child is the enormous gift from the Almighty. You don't know how it happened. So for the freshers, I mean the medical officers, pregnancy, if otherwise no other, I mean there are no other reasons not to having it, there is even a big surgery, cancer surgery or whatever, the patient can still conceive. I give you 2-3 examples. For example, total thyroidectomy, radioisotope. Then common question: am I going to have a? Is it going to be a problem if I'm pregnant? It's not. Patient can conceive. Patient can conceive. Cancer surgery. There are other ways to preserve your ovums and those sort of things. Of course, before chemotherapy, we have to look after that. We have to preserve the ovum and so on, so that the patient can go for surgery. But sometimes patient also ask questions to everyone that, okay, I had this big major surgery. Can I go for conceiving a baby? Yes, it is. Until otherwise it is proven that you cannot conceive. Never desert the patient. No, you are not. In any difficult situation, the patient usually no problem with pregnancy. Like I had one surgery, that transhiatal esophagectomy and the colonic pull-up. This is a big surgery, 6 major anastomosis inside the abdomen. And to our utter pleasure, the patient had a beautiful a baby born after 2 years, I think, sir. After 2 years, and without any difficulty. And that was a beautiful, birth of a newborn. So the thing is, pregnancy is not difficult, but the modes we have to according to the situation. Yeah. Thank you. But another thing is the chemotherapy. We are in Bangladesh. We are still unaware of preserving the ovum. Before chemotherapy, of course, we have to look up to it. We have already centers in Bangladesh where we can cryopreserve our ovum and sperm as well. So please do consult with those issues. I mean, do not let your patient go for a chemotherapy in the reproductive age. Even the family is complete. It should be there because you never know what can be the situation in the future. Thank you. Sorry, sir. Dr. Mustafa.
Assalamualaikum, sir. With your permission, I want to add a comment after in this comment. Osteoporosis, we see that major screening, major risk factor for genetic femur fracture or other accidental fracture. But we see that very small diagnosis, very few diagnoses we found usually osteoporosis in the prescription or other. But it is a must diagnosis should be done after post-menopause. After 45 years, the risk is increasing and it can be prevented, it can be delayed with a simple test, that is the PMD. Actually, when we do, usually all our doctors and our patient, when comes to see a doctor, when pain in the back region or in the femur or any other side. But when is pain, there must be fracture. Osteoporosis is painless. We must know that osteoporosis is painless. And it is diagnosed only by BND. So after 45 years of a woman, a hypogonadal young patient, or after 60 years a male, it should be done routinely. BND should be checked every 3 years or after 5 years, whether symptomatic or asymptomatic. And I want to give a message to all. This is thing. Thank you.
Thanks for your presentation. I have two questions. It is the high mortality in there. My question is it without the treatment or with treatment or overall? The mortality is overall or with treatment or without treatment? And does early treatment prevent this mortality? One thing. And the thing is that what is the cause of the mortality? Because simple fracture doesn't cut up. It should have some other reasons to cause the patient to die. So what are those moves?
Thank you, sir. Such a nice question. Regarding mortality of this type of fracture, think about the lifestyle of this patient. A patient has a fracture in the neck region. His or her personal hygiene. Regarding mobility, taking food and go to the washroom is very difficult. There is a poor psychological state from which he or she gets the help to go to the toilet, to change her dress. The patient take less diet. So constitution is malnutrition is very common. The patient is helpless on the bedridden. There is no nursing or helping people. There is bed sore. The patient have some muscular disease, less movement, less movement in the limb. Impact from only the incidence of the limb. And as the patient in cough reflex, these are the very poor. Orthostatic pneumonia is very common. And if we delay 2 days, 3 days, 2 weeks, 3 weeks, all the things will increase the chance of mortality chance. After doing surgery, the patient have early mobilization, we can overcome this burden. So obviously it improves the vitality of the life and prevent the complication. Thank you, sir.
Actually, there is a saying, we came to this world under the pelvis and we leave this world by fracture of the pelvis or hip. This is a natural scenario. Okay. Then particular question was whether we do intervention or not, mortality affected or not. Question was such question, I think point was there. Definitely intervention reduces the mortality. And how in a fractured neck femur or by a fractured trochanter, patient will not die from hypovolemia or hypovolemic shock. He or she will not die. But how the mortality rate increases without intervention? Because from the brain up to the toe, everything is become either blood become more clotted, chest become less oxygen tension, there is pneumonia, and the more the patient is bedridden, the more the comorbidity will accelerate. All these will lead to his or her increase of mortality. From the direct cause, the fracture, that will not kill the patient. Okay, sir? Thank you, sir. Sir, please.
That's what I'm trying to understand is the mortality is overall. That means if anyone doesn't undergo any sort of treatment, he will die. The mortality will be high. Or if anyone goes early treatment, mortality will go. And this mortality, that is the given there, is it overall mortality or the with or without getting the early treatment?
Sorry.
This mortality is usually signified without surgery and without early mobilization.
Okay, thank you, Salam, and good morning to all. Thank you, Dr. Mahbubul Alam, for your nice presentation. And I also thanks to our expert panel, Dr. Gazi, Hasan, Firoz. Actually, sir, what is he saying that is there any data that shows that if we don't go for surgery, the mortality rate, and we go for surgery, mortality rate? Is there any comparative study in your society or in your publication is reflecting such type of data is present or not? Then we can say that yes, the result is better. Pathology we know, pathologically patient of course without surgery you will be more chance of mortality. I'm just adding it, sir. Is there any data or any information regarding this that without surgery the mortality is high, after surgery mortality rate is low? Is there any data?
Thank you, sir. Such a specific question. There is no exact data in our country. This data presented from the studies from USA. The dream is very much clear. Without doing surgery, we cannot overcome this type of burden. The patient have diabetes, the patient have lung compromise, the patient have hypervascularity. These are the facts. Exact mathematical data in our patient group, I did not find in this study. If I found, then
yeah, okay, sir, thank you. Actually, this is happening that such a geriatric patient with lots of comorbidities, and with this addition, there is a fracture. So it will not help to reduce the mortality. Definitely, it will encourage the mortality due to other conditions. So, my grandfather also, I think that cognitive fracture ultimately died due to bedridden, ultimately cell degeneration. There is a hypertension, stroke, followed by injection, massive nursing care. With all those, but and we also do the DHS, dynamic scope. After this, he died within 1 month. No, that it does not. We don't take it negatively. There is a problem. There is a solution. As a doctor or as a normal person, we should always try to help the patient or the person. To make you, orthopedic surgeon, always try to make him better, feel him better, do his normal activities, do movement, do his regular daily activities that we all want. But sometimes it may not be happen due to some other conditions like comorbidities. I just want to stop it here. My question was actually, is there any that we calcium? We have already or talked about this. What about the vitamin D level? The D level, calcium D, vitamin D level. This is one of the most, I think, the vital and important factor that should be assessed in the osteoporotic case, I think. It is said that in about 20 to 25 patients, one patient has low vitamin D level. So it is another important factor that makes the femur fracture also more vulnerable. We don't, I think, I don't know that you can say that properly that in our country also there is no data regarding the vitamin D level. So how is there, before you doing the surgery, you may do the calcium level. Whether you do the vitamin D level or normally or not.
Thank you, sir, for raising the question. Actually, after this type of fracture, all things come in our attention. Obviously, there is hypovitaminous D, there is also less calcium stored and bone quality is poor. Regarding good outcome of this patient, we are in confusion. The patient is elderly patient, too many comorbidity, too many previous surgery. Whether the surgery is helpful for him or will endanger the patient life. And taking consideration of this thing, we do the surgery. Another important thing and another important part of our orthopedic wing, that is in rehabilitation and physiotherapy. After doing surgery, it is very, very much important to get help from our physiotherapist brain, to mobilize the patient, to do the activity of daily living, with helping in the early stage. If they do effectively, obviously it will increase the good outcome of the surgery. That will prevent bed sore, that will prevent the orthostatic pneumonia and other complications. Also good sugar control, this thing, and also the patient having confidence. He or she can do herself her activity independently. That will obviously increase the rate. Regarding the investigation parameter, hypovitamin D is very common. And good sunlight exposure, taking food, having this source of vitamin D is good. And it is sometimes the patient take calcium by themselves, but absorption of calcium in the body, not only taking from the tablet source is not good, it is good to take from the natural source. And regarding consideration of the acidic phase of the stomach, so many of the calcium they took as a food, nothing is absorbed in the blood level and then the acid is in brain. Thank you, sir. To improve the outcome of the surgery, obviously we need the help from the rehabilitation persons.
Two more questions.
I want to add a comment after Shubhu sir's question, that calcium and vitamin D level, actually in osteoporosis is the total bone mass reduction. The calcium and vitamin D level is normal. So when is calcium and vitamin D is reduced, it is osteomalacia. And osteoporosis is calcium and vitamin D is normal. So it is not necessary to do routinely the calcium and vitamin D level.
Good.
Whether it is when it is reduced, is increase the risk of fracture. But in osteoporosis, the level is normal.
Thank you, sir. We will do everything, but what the other colleagues will do, we have to leave something for them. We will do the surgeries, okay?
Just only one question. Everybody is Assalamualaikum. I have one question to you. I know all the proximal femur fracture, the treatment is surgery. That is the alignment, either internal or external. Is there any scope of external fixation or external direction, like the Elizarov, in where the patient is having so many comorbidity, internal fixation is based on total fibrillation like this, there is the comorbidity patient. Is there any rule of external fixation like Elizarov in the treatment of proximal femur fracture?
Thank you, sir. Regarding Elizarov is a actually external ring. In the proximal part, we need to abduct or we need to lie by the sides. So if we put an Elizarov in the proximal femur, it is very painful for the patient, very painful. So unless there is particular indication, we do not go for external fixation. We always prefer internal fixation, either in the form of neck screw or dynamic hip screw or hip replacement. So we usually avoid in the proximal femur Elizarov fixation. Of course, there is a scope, but there is particular indication. Thank you, sir.
Thank you, sir, for your nice presentation. Actually, I would like to know that after this operation, what are the problem patient face on mobility, single or double, whatever, if you are doing operation, is there restriction on movement? Is there?
Thank you, sir. Actually, no surgery is very comfortable. As our research say, what is naturally given, we can never go up to that standard, never. So, regarding say hip arthroplasty, one of the example, definitely there are some restrictions. Like for the time being, you cannot go for squatting. Like you cannot sit in the ground by cross leg. It is contraindicated because there is every chance of posterior capsular disruption. But with time and with better implants, scientists are trying that okay, you can squat, you can sit down, and it is early. Of course, there are some other complications like infection, loss of reduction, and even periprosthetic fracture, because it is, we are discussing about osteoporosis. When we bear the weight, metal is there, but bone is not a metal, it's a living tissue and it is already weak. After walking, after 6 or 8 months, there is fracture around the processes. So everything restricts the morbidity of the outcome of the surgery. But doing nothing will lead him or her to more painful conditions. So we need to do something for him or her.
Let me add something regarding this issue. After surgery, if we put prosthesis, it is near to natural axis to put weight. And if we fix it by device, we have to wait for the healing. And after fracture, the patient lost his or her confidence, whether he or she put weight or not. After doing replacement, we encourage putting weight next day of the surgery. Obviously, this involves many things. After putting a fixation device, we wait for the healing state. And in that case, we advise walking aid to mobilize the patient. The condition is less painful. As the fracture is fixed, there is no fracture movement, there is no bleeding. The patient is in a good state. He or she comfortably walk with walking aid. Thank you, sir.
Thank you. Just comment, I think echoing Dr. Mahbubul's comment regarding rehabilitation. I think that is you can perform surgeries. If a patient requires surgery, you can perform. But the post-operative rehabilitation, I think, is vital in going back to your original self. Yeah. So normally when a patient is well after surgery, will discharge home, right? And you would naturally advise them, you have to go for rehab, you have to exercise, walk, don't squat, don't lie down sideways, and so on and so forth. Maybe we could, to ensure that your patients follow and the rehabilitation, probably we can suggest to continue the stay, not hospital stay, but we have guest house, and and just to make sure that at least in a week's rehabilitation that they follow exactly. God knows what they do when they return home, and continue working when they're not supposed to work, and so on. So maybe we can charge a nominal, for the stay, for the food or whatever. But what is most important is the rehabilitation, ensuring that they follow the regime and for whatever duration that you require them to do. So maybe we can think of that. Yeah.
Thank you, sir.
Assalamu alaikum. I want to give thanks to Mahbub sir for his valuable presentation, very informative. Sir, I have to ask a question that surgery is very good option for the patient mobility and for his lifestyle, improving quality of life. But in some cases, we got some patients that they don't want to surgery. They're afraid of to do surgery, or there is malnutrition and they have pain and they have limitation in walking and activity of daily living. So what kind of advice do you like to give for those patients, and how long they will do follow up with you for their betterment? Thank you, sir.
Thank you, Sheikh, for your nice question. So many of our patients not willing to do surgery. In case of neck femur, there is no chance of actually healing, and the complication is more, and limb length discrepancy is more, and the bone integrity is totally lost. So in case of neck femur fracture, there's so many problems. But in case of trochanteric or subtrochanteric fracture, there is union, and there is shortening of limb, there is rotational abnormality. And in that case, the answer is taking help from the real person. That is correction of shortening of limb by shoe correction, using of walking device, and modification of bathroom, and using of walking or mobility device in the house, and improve the muscle power and quality of that type by doing exercise, targeted exercise, that kind of under situation. And that's why we put importance to this. Take the message. This is the fracture of old age. It has a good treatment option by doing surgery. Obviously, it increases the quality of life. If we do delay, we cannot get the benefit of this type of surgery. Thank you, sir.
Direction that anyone refuses surgery, how we can help him. Question was like something like that. Actually, without consent, we cannot go for surgery. Straightforward. Okay. Number one. Number two. Okay. If there is any scope, okay, the rest of the life we need to rehab. Okay, you can go for rehab, but it will be painful. It will be painful because periosteum is pain sensitive, and after every movement, he or she will be in pain. But answer is, without consent, we cannot go for surgery, whatever the condition is.
Dr. Ishat, I want to do a final comment. After this no comment, go for the next one. Okay, first of all, so there is no other option but to go for surgery. And the other thing is, the most common question from the patient is not about the surgery, about the sleep that they will go for the surgery, meaning anesthesia. So we have to, well, there are a lot of ways to make it safe. Of course, anything is dangerous, but there is a lot of ways to deal with the dangerous steps. And our modern anesthesia, the experience of anesthesiologists, the excellence of the equipment, anesthesia has become safer. I should not say safest, but safer than what was it was previously. It is not 1952 anesthesia; it's 2000 and beyond anesthesia. It's quite safe. Think about the cardiac surgeries, CAPG and beyond. All those, you stop the heart, do the surgery, and restart the heart. So the neurosurgery, you are cutting the brain, and the patient is gaining the consciousness again. Meaning, anesthesia is nowadays is very, very safe. Of course, there are pitfalls, but well, to date, it has become quite safe to do surgery. So I don't think cutting bone off and doing a prosthesis is not that risky. It's not life risk. The main concern is about anesthesia. They cannot think I will go sleep and I will wake up again or not, doctor. That's the question that usually patient asks. So assure your patient you are in good hands. They are doing a lot of replacement surgeries. They have done bilateral knee replacement. They have done bilateral hip replacement, which is very common in our hospital. But choosing the right person, a right hospital, a right anesthetist is very important, who can deal with your problem. So assure your patient, and don't patient go through all this painful rehab after the fracture. Only this is not a treatment. The treatment is one, surgery. Go for surgery. No option. Another, I want to comment for the this one, the data. We always regret that we don't have that data. Have we tried in our hospital? Why we are only blaming Bangladesh? We have to have your own data. Did we do ourselves? Why am I blaming my forefathers and afterwards? Let's do it. The medical record is there anyone? Shubro is here. So you have the topic. Poke your medical record person to come up with the data, how many fractures they have already, and what with sir. If your orthopedic department publishes data with your records, your hospital has come up with something to the nation. Do it.
So we can ensure that any data.
Well, okay. So try. I really want to request each of our consultants come up with the data and this sort of thing. Don't blame Bangladesh. Bangladesh is nothing but you. If you're not doing, who is going to do? The patient is with you. So get your data. Publish our experience. Don't think Mayo Clinic has published genetic expression. I have to do that. We are not up to that level if you think in that way. But whatever your level, there is no harm in publishing your population, your patient. It may be a simple, but maybe important. Maybe not helpful for the Americans, but it is of course helpful for your people. So do not feel smaller that I'm not doing as big as the American doctors. We are not America, we're Bangladesh. We have even much things to do for our people. So data presentation, collection, this is very important. I like really Dr. Shubrata's question, just whether you have data. Maybe we can, in further presentations, the future presentations, we can add some, maybe our own data. It's very easy to collect data from the PMS. And also we can show some publications. We went to Reliance Institute, we saw some conferences, and there is nothing, there is no theoretical lectures. It's only data and data. This authors published this one, this author published this one, so I have come to this sort of conclusion. That's how the world is running. Maybe we can also do like that. Please take into consideration to the CME chairman. He was also with. Actually, we were following him in the consensus conference. So I think the CME chairman also look into it, that when we present, we put some data from the world, so that there's nothing harm how they publish. Like the survival issues, of course. I guess I'm sure there is publications about the mortality after the surgery or without the surgery and those sort of things. So please come up with that. And vitamin D is a costly investigation. I'm sure sir is not here. It's a costly 4,500 taka. It's a costly investigation. Thank you.
Thank you, sir. Regarding this case, it is very important to put data from our pet side. It is clearly evident by the X-ray. Observing the data from radiological department, how many patients have this type of fracture and how many patients underwent surgery. Very simple. It is possible if the radiological department help us. Thank you, sir.
But we have our own journals. It's about maybe we need it. So in a journal, I would expect a publication from the author. Maybe as simple as this. What's the problem? It's our experience.
Thank you, sir. Thank you, sir. I think question and answer session was very lively. We are very much thankful to our today's panel of experts, Dr. Mahbubul Alam and Gazi Hasan Firoz, sir. Both you answered very nicely. Thank you again, our MD sir, for your nice comment regarding our today's topic. Now we would like to conclude our question and answer session. And this time for Beximco Pharma, today's CME session, Beximco Pharma is sponsored.